Anxiety disorders are among the most common mental health conditions encountered in primary care. They encompass a range of conditions characterized by excessive worry, fear, or nervousness, often leading to significant distress and functional impairment. Primary care providers (PCPs) play a crucial role in identifying, diagnosing, and managing these conditions. 1. Epidemiology. Anxiety disorders affect approximately 18 to 25% of adults in the U.S. at some point in their lives. More common in women than men, often coexist with depression, substance use, and medical conditions such as irritable bowel syndrome (IBS) or cardiovascular disease. 2. Common anxiety disorders in primary care. A. Generalized anxiety disorder (GAD), characterized by excessive, persistent worry about various aspects of life. Symptoms: muscle tension, restlessness, fatigue, irritability, difficulty concentrating, and sleep disturbances. Diagnostic criteria: DSM-5, worry lasting is greater than or equal to 6 months, difficult to control, with is greater than or equal to 3 associated symptoms. B. Panic disorder, recurrent, unexpected panic attacks with intense fear and physical symptoms: palpitations, chest pain, dizziness, shortness of breath. Fear of future attacks often leads to avoidance behaviors. Rule out medical causes, e.g. arrhythmias. Hyperthyroidism. C. Social anxiety disorder, SAD, intense fear of social or performance situations leading to avoidance, commonly associated with blushing, sweating, trembling, can be debilitating in work or academic settings. D. Specific phobias, irrational fear of a particular object or situation, e.g. heights, flying, needles, triggered by exposure, leading to immediate anxiety and avoidance behavior. E. Post-traumatic stress disorder, PTSD, follows exposure to a traumatic event. Core symptoms: re-experiencing, hyperarousal, avoidance, negative mood changes, often coexists with depression and substance use. F. Obsessive-compulsive disorder, OCD, characterized by intrusive thoughts, obsessions, and repetitive behaviors, compulsions aimed at reducing distress. Common obsessions: contamination, safety, symmetry, common compulsions, hand-washing, checking, counting. 3. Diagnosis and screening. Primary care relies on screening tools to aid in diagnosis. Generalized anxiety disorder 7GAD-7 screens for GAD. Patient health questionnaire for PHQ-4, brief screening for anxiety and depression. Panic disorder severity scale, PDSS, assesses panic disorder severity. PTSD checklist for DSM-5. PCL-5, used for PTSD screening. 4. Differential diagnosis. Anxiety symptoms can mimic or coexist with medical conditions: cardiac, arrhythmias, mitral valve prolapse, endocrine, hyperthyroidism, pheochromocytoma, neurological, seizures, vestibular disorders, substance-induced, caffeine, stimulants, alcohol withdrawal. 5. Treatment approaches. A. Lifestyle modifications and behavioral interventions. Cognitive behavioral therapy, CBT, gold standard for anxiety treatment. Mindfulness and relaxation techniques. Meditation, deep breathing. Regular exercise reduces symptoms via endorphin release. Sleep hygiene, address insomnia. Limit caffeine. B. Pharmacologic treatment. 1. First-line medications. O. Selective serotonin reuptake inhibitors. 3. Sertraline, escitalopram, fluoxetine. O. Serotonin norepinephrine reuptake inhibitors. SNR is venlafaxine, duloxetine. O. Take 4 to 6 weeks to show full effects. May cause transient initial worsening. 2. Second-line medications. O. Buspirone, non-sedating, used for GAD. O. Beta blockers, e.g. propranolol, useful for performance anxiety. O. Tricyclic antidepressants, TCA letters, and monoamine oxidase inhibitors, MAOIs, reserved for treatment-resistant cases. 3. Benzodiazepines, e.g. alprazolam, lorazepam. Clonazepam. O. Effective for acute relief, but not first-line due to risk of dependence. O. Short-term use for severe cases. 4. Hydroxyzine, antihistamine. O. Can be used for short-term anxiety relief, particularly in those avoiding benzodiazepines. 6. Special considerations. A. Anxiety in children and adolescents often manifests as somatic symptoms, e.g. stomachaches, headaches. CBT is first line, followed by SSRIs when needed. B. Anxiety in the elderly may present with memory issues, mimicking dementia. Start SSRIs at lower doses due to increased sensitivity, anxiety in pregnancy and postpartum. SSRIs e.g. sertraline are safest. Benzodiazepines should be avoided due to fetal risks. 7. When to refer to psychiatry: severe functional impairment or treatment-resistant cases, suicidal ideation or self-harm risk, suspected OCD or PTSD needing specialized care, substance use complicating treatment. 8. Key takeaways for primary care: screen regularly for anxiety in at-risk patients, use CBT and SSRIs as first-line treatments. Consider secondary causes e.g. thyroid dysfunction, reserve benzodiazepines for short-term or severe cases, refer to psychiatry. When needed,